in the primary and community cancer centers, more than 200 respondents. And of the 200 respondents, 96% said they prescribed immune checkpoint inhibitors, which is what you'd expect in the community setting. Of those prescribers that prescribe, or of those that prescribe immune checkpoint inhibitors, 40% said they were very uncomfortable or somewhat uncomfortable with managing immune checkpoint inhibitor toxicity. And so that really highlights that everyone's prescribing the immune checkpoint inhibitors, but a lot of physicians don't feel comfortable with the management of the toxicity of the immune checkpoint inhibitors. And so I really think there's a need for pharmacists to be very involved in the whole continuum of care of patients receiving checkpoint inhibitors. This is the list of all the checkpoint inhibitors approved. A lot of combinations are coming. And so I think that highlights the amount of the need for pharmacists to be involved, because we're going to be seeing more and more checkpoint inhibitor toxicity. All right, so what is this? Well, this picture here on the top left-hand corner, you sort of have the angry tumor and the T cell that is not able to see the tumor. And then when the checkpoint inhibitor is given to the patient, then you see the release of brakes, T cell activation, now T cell that is attacking the sort of sad tumor. The background on this is that when I started the presentation, or creating the presentation, is that HOPA wanted copyrights for everything, and I didn't want to pay for a mechanism, and so I had my son help me draw this, actually. So, and he really did a great job. I was really amazed. My drawing is much worse than this. All right, so patient case. This will lead into our first ARS question. 56-year-old male, metastatic melanoma, diagnosed in 2017. A little bit of background information on him, mainly pathology, BRAF negative, PD-L1 5%. Baseline labs drawn, nothing really significant to note on baseline labs. All right, so the patient was recommended to start the combination of nivolumab and ipilimumab, so PD-1 and CTLA-4 inhibitor combination. Started in September 2017, 11 days later, rash to the face, chest, and arms. You can see here, grade 2 upon examination, so about 10 to 30% of the body surface area covered with this rash. So it leads into our first question. Upon examination, the patient has a grade 2 rash, covering approximately 10 to 30% of the body. What is the most appropriate course of action? All right, so I can see some people are responding in the top right corner. I'll give you about 5 more seconds. All right. Okay, good. Actually, this is quite a tricky question, and that's why I wanted to put this in the beginning. There is a wide range of answers here because, because of the question being a little bit difficult to answer, and you can go kind of a couple different ways. What sort of excluded A, C, and D is the high dose of steroid in that case, and in patients that have a pretty extensive rash, especially kind of sort of towards the upper end of the range of the 10 to 30%, especially if they're affecting their quality of life. The answer would be oral steroids, and usually a lower dose, a 0.5 milligram to 1 milligram per kilo of steroids. But in a lot of cases with high potency topical steroids, you can control it, especially when it's on the lower end of the range. So this is a little bit of a tricky question. Here's the range of toxicities seen with immune checkpoint inhibitors, from common, uncommon to rare. The incidence of this does vary based on a lot of different factors. One, the drugs, and if they're used in combination. Also, the patient baseline risk factors. For example, if they are coming into treatment with other predisposing risk factors for immune checkpoint inhibitor toxicity. But also, for example, with durvalumab used for adjuvant stage 3 lung cancer, higher rates of pneumonitis seen when they're post-radiation. Okay, so this slide shows sort of the nivolumab as a reference, showing the overall toxicities with a single agent, PD-1. And what I wanted to highlight really is that overall, a couple things, that is very well tolerated. low rates of grade 3, grade 4 adverse effects that would require treatment discontinuation in general. 7.7% of people in phase 3 study discontinued treatment. But then also that in the case of PD-1 inhibitors and PD-L1 inhibitors, dose in terms of toxicity does not matter, and that the nivolumab study is looking at 2 milligram per kilo versus 10 milligram per kilo, no difference in adverse effects. And that's why this approval of the nivolumab 480 milligrams every 4 weeks really makes sense from a toxicity standpoint, is that there's no difference in adverse effects. Ipilimumab, looking back at the first checkpoint inhibitor approved, 3 milligram per kilo, higher rates of treatment discontinuation. What I wanted to highlight a couple different things here. With ipilimumab, you see higher rates of GI effects, so colitis, with the CTLA-4 inhibitor than the PD-1 inhibitor, but also higher rates of adrenal disorders, including hypophysitis. Whereas the PD-1 inhibitors have higher rates of hypothyroidism, along with higher rates of pneumonitis. And then looking at dose does matter with the CTLA-4 inhibitors. Now, this is sort of going by the wayside with the approval of nivolumab in the adjuvant setting of melanoma that sort of took over the use of the ipilimumab 10 milligram per kilo dosing. But just showing how hard it is to tolerate the 10 milligram per kilo dosing of ipilimumab with treatment discontinuation rates above 50%, and very high rates of grade 3 or grade 4 colitis. The next is nivolumab and ipilimumab combination. And this is specifically the dosing that's been approved in metastatic melanoma, using the ipilimumab 3 milligram per kilo for the first 4 doses. See very high rates of treatment discontinuation, 36%, but also a high rate of grade 3, grade 4 adverse effects, hepatitis and colitis. And so if you are a center that does use this combination frequently, I think it's really important to have a good understanding of immune checkpoint inhibitor toxicity management, especially the common but also the uncommon toxicities. And there's a really great review from Jessica Hassel in Cancer Treatment Reviews 2017 that is really focused just on combination checkpoint inhibitor management. And it's really good examples of how to manage unique situations. And just showing the kinetics of when this occurs, timelines with PD-1 inhibitors, more in that 4 to 12 week range, although it can happen at any time and even after treatment discontinuation. But looking at the combination CTLA-4 and PD-1, look at the difference, the kinetics on it, and how early the checkpoint inhibitor toxicity occurs is really important. And that when I had some physicians, and I work primarily in a sort of a community-based practice, some physicians were surprised how early the checkpoint inhibitor toxicity was happening, sometimes within days of starting, because they're used to with the PD-1 inhibitors in lung cancer, for example, this sort of delayed timeline. All right, so this is how I model the rest of the talk, is really around this slide, and it's a continuum of care. This is all going from education being the most important. Everything goes back to education. That's where I think the oncology pharmacist can be very involved. But leading all the way from anticipation to evaluation, administration, and then observation of the toxicities. And I'm going to talk about these in order. So anticipation, this is where I actually do get a lot of questions, and I feel like many pharmacists probably do get a lot of questions about, is this patient appropriate for treatment, and if so, what treatment, based on their specific status. And I get a lot with autoimmune diseases, questions about that. Prior transplantation comes up too. And really it comes down to a risk-benefit ratio in the specific patient, because there's not a lot of data to guide. There is some now that's been coming out in retrospective reviews, but not a lot of data to guide in prospective studies, because patients were excluded from the studies with the checkpoint inhibitors if they had prior autoimmune diseases and prior transplantation. And then medications, important to look at, and especially making sure patients, if they are on corticosteroids or steroids, really trying to be getting them off as soon as possible, and that they shouldn't be on continuous steroids if possible. And then on the anticipation baseline labs, this is sort of the bare minimum that I wanted to include here. But in select patients, this needs to be more extensive. And I think especially with the combination checkpoint inhibitors, I think it is important to look a little bit more on the endocrine side at baseline. Also, if they have diabetes, hemoglobin A1C, and pulmonary function definitely too, having a good baseline on them. All right, so now what happens? So a patient develops a checkpoint inhibitor toxicity, and really you're evaluating one versus the other. So this is really important, that you can't just assume that this is specifically a checkpoint inhibitor, and that's the cause. You need to consider progression of disease in many cases. So neurologic toxicity, for example, if they're receiving agents and they're having new onset neurologic toxicity, headaches, and so on, is it the checkpoint inhibitor or is it disease progression, especially in the case of metastatic melanoma? On the cutaneous side, for example, a new rash, new dermatitis, is that a rash from a new drug, new antibiotic, for example, or is this checkpoint inhibitor toxicity? Same thing with progression with nausea and vomiting. Is it progression versus potentially GI effects of the drugs? And then diarrhea, definitely. Is it the drug itself, or is it from other causes, C. diff, for example, or other colonic infections? So what I tried to put in here in this table is kind of large, but sort of the grading. And I think you have to have a good baseline knowledge of the grading in order to really guide treatment at that in these cases. So looking at grading of rash, colitis, hepatitis, and pneumonitis, I put this in for more information. But the NCCN guidelines does a great job really laying this out more extensively for you. And really just pointing out with colitis being so frequent with patients, really having a good understanding of what their baseline is before considering the grading of the patient. All right, so general guidelines, this is also a little bit tricky because there are cases where this doesn't necessarily ring true, but looking at general guidelines, grade 1 in general, you'd continue immunotherapy, and in most cases would not require steroids. Now there are cases where that may not always be true. Topical steroids, for example, for grade 1 rash is completely appropriate. And then there's some cases, such as nephritis, that may require steroids, even if it's just grade 1. Follow-up is definitely close monitoring, seeing patients frequently if grade 1. On the side of grade 2, though, in most cases, treatment's going to be delayed. In topical steroids for skin, or sometimes oral steroids if an extensive or affecting their quality of life. And then in most cases, such as GI, colitis, or hepatitis, it's going to be oral or IV steroids at that point. And then if it improves and it goes back to grade 1, then in most cases you can continue treatment. While as it persists, then you need to really consider upping the steroids and doing or including steroids if you didn't already. If it's worsening, then treat as a grade 3 at that point. Now with grade 3 and grade 4, in most cases treatment's going to be discontinued. Now there are some exceptions to that, definitely. And there are cases where if the patient was receiving a CTLA-4 inhibitor, and it's appropriate to use a PD-1 or PD-L1 inhibitor, that could be substituted in that patient's case if the adverse effect or the immune toxicity improves significantly down to a grade 1 or better, and the patient was off steroids at that point. And then in terms of steroids, oral or IV, depending on the case, most of the times it's going to be IV, and in many cases, admission into the hospital. And then the key here is really slow taper, and don't taper too quickly. I think oncology pharmacologists are really uniquely knowledgeable in this area, but a slow taper often over at least a month. Okay, so what happens if at the point that the steroids don't work and the patient's steroid refractory? So in terms of colitis, hepatitis, pneumonitis, I put a little bit of information in here. And so what doesn't work? No improvement after 48 to 72 hours or worsening. So in those cases, optimize steroids. So if the patient was started at a half or 1 milligram per kilo, really increasing to a max dose of 2 milligram per kilo per day. And then considering infliximab in most cases. And then really this is where patients are often requiring long tapers, often at least 6 weeks, in many cases up to 10 to 12 weeks of a long steroid taper. There is one exception to this, hepatitis, really avoiding infliximab because of the liver toxicity associated with infliximab, and considering alternative agents. And if the patient doesn't respond to infliximab, then there's a host of second-line agents that have been studied. One that's come up more recently in the area of colitis, which is more common to not respond, especially in a severe colitis case, and considering vedolizumab, which has activity in other disease states such as Crohn's, and has been shown to have some activity in the double refractory patient. Okay. So observation, what I mean by that is, so the patient's been treated with steroids and or other agents, and now we're considering, what do we need to do at this point? And so monitor for time to resolution of toxicity, and this is the case where we're really looking at other things, what else needs to be considered. So tapering of steroids, I think it's really helpful to have a calendar in place and really to follow and make sure that the patient is being steroid tapered. I've seen cases in the past where they're followed, once every 2 weeks, and we really should be trying to push the steroid taper down as quickly as possible to avoid infectious issues. And then consider the dosing and the duration of steroids and other immunosuppression. So for example, do patients always need proton pump inhibitors or H2 blockers if they're receiving high doses of oral steroids? No, they don't. If the patients are receiving NSAIDs along with steroids, then that can be considered. Or if they're receiving other anticoagulants, for example, that can be considered. But in general, patients don't always need to be on proton pump inhibitors or H2 blockers when on steroids. Antimicrobials, that's a really interesting area. When they're on long tapers of steroids, definitely consider PC prophylaxis and antifungal prophylaxis in specific populations. So NCCN guidelines, for example, recommends if they're on greater than 20 milligrams of prednisone for more than a month to give PC prophylaxis, which most patients that have these toxicities, especially the colitis, hepatitis, and pneumonitis, are going to be on. Consider pneumocystis prophylaxis. And then antifungal prophylaxis is really considered if they're on a very long taper, often 6 to 8 weeks or longer. There was a great article in Clinical Infectious Diseases cited in the bottom from Memorial Sloan Kettering as a retrospective review. 740 patients had received checkpoint inhibitors, mostly ipilimumab, just given the time frame of the study. And 740 patients, 46% of those required steroids during the study. Of those 46%, 16% required infliximab also. And of those patients, they saw, and 42% got PCP prophylaxis in this retrospective review. Of the patients, 2 developed PCP pneumonia, and 3 developed aspergillus pneumonia during this or in this retrospective review. And so it just highlights that there is a decent frequency of patients that develop these fungal or PCP during the steroid taper. Also, if patients are receiving infliximab or other agents that are broader than just steroids, consider infectious disease testing. Do the hepatitis B, hepatitis C panel if not already done, and also do TB testing if they're receiving these agents. Okay, so what is the impact of stopping treatment, or what is the impact of giving steroids? And what this shows, what these 2 studies show, is that there's really appears to be no difference in progression-free survival and overall survival in patients that discontinued immunotherapy versus did not. And that really the important key point here is that you need to stop early or hold treatment early. There's nothing wrong with holding treatment on a specific day if you're concerned for an immune checkpoint inhibitor toxicity and letting it resolve. And then second, giving steroids does not impact clinical outcomes, at least at this time point. And so I think it's really important that we play a role in stopping this inflammatory cascade early and education of providers that it's important to stop early versus later. All right, so leading into our next ARS question, patient seen 4 days later, improvement to grade 1 rash. Cycle 2 was initiated. Patient called the triage line, had nausea, diarrhea, 4 liquid stools the previous day, 4 liquid stools today, and seen in the clinic. And so here's a key indicator of how severe, with abdominal pain, how severe the GI effect of colitis is. Abdominal pain normally has 1 to 2 stools a day. Stool sample sent for C. diff, ovoparasites, grade 2 symptomatic, but was sent home just with loperamide in this case. So they call back the next day, worsening diarrhea, 10 stools, 24 hours, still with abdominal pain that's worsening. Patients admitted with a colonoscopy scheduled, stable with no blood and diarrhea. What management options are most appropriate at this time? All right, I'll give you about 10 more seconds. All right, great. Nice work. That's perfect. Yep. So steroids, IV steroids at that point is the correct answer. Okay, so what is available now for everyone in terms of references? And this is the 4 guidelines that I referred to. And I just wanted to sort of highlight the ASCO and NCCN guidelines, really well written, multidisciplinary, and I think I prefer the NCCN guidelines. I think they're really easy to follow and really go disease state focused. Okay, so last slide. Implementation of systematic changes. And what I wanted to point out here is that I really do think pharmacists can be very involved in the whole continuum of care of patients receiving checkpoint inhibitors, especially on the staff and patient education level. So on the staff education, from the practitioners all the way through nursing, triage is actually what I found to be so important to do education, because what I've seen in the clinics is that triage turnover is actually, it seems to be, at least where I work at, fairly rapid. And having education, not to just provide loperamide in cases, and really to know when to have the patient come in to be evaluated, especially in the case of colitis or GI toxicities, but really knowing when to refer, when to call, when to have the patient come back in. Also, ancillary services, very important to be involved in this, and then emergency department, because these are providers that don't see these frequently, and they can be helped out through patient education with handouts, and so sort of enabling or empowering the patient to be involved in their care, but then also wallet cards on the immune checkpoint inhibitors, and really the sort of having guidance for patients when they go to the ED, what to tell the ED staff and to make sure that they get referred to the appropriate team. So with that, I'm going to turn it over next to Sam, who's going to lead right into the next talk. And then at the end, if there's time, we'll have time for questions.
All right, good morning, everyone. So I work specifically with neuro-oncology patients, and with neuro-oncology, we rarely see any new drugs that are approved for treatment of CNS tumors. So when this literature came out about treating brain mets in lung cancer patients, I got really excited, so I'm really happy that all of you are here to join my talk on overcoming the blood-brain barrier, new opportunities for the treatment of brain metastasis in non-small cell lung cancer. Here are my disclosures. For my objectives, by the end of this presentation, I want all of you to be able to describe the epidemiology and incidence of brain metastasis, or brain mets, in patients with non-small cell lung cancer and the challenges of treating it. I want you to be able to discuss the epidermal growth factor receptor, or EGFR, and anaplastic lymphoma kinase, or ALK, tyrosine kinase inhibitors, pharmacokinetics, cerebrospinal fluid penetration, and safety profile. Lastly, I want you to be able to review the intracranial efficacy of EGFR and ALK TKIs. Lung cancer is the second most common cause of cancer in the United States and the leading cause of cancer-related death in the US, with an estimated over 150,000 deaths alone in 2017. CNS mets are a common complication of many systemic cancers and is more common than primary brain tumors alone, and lung cancer alone is the most common source of brain mets. And in the recent years, there has been an increased incidence of brain metastasis in non-small cell lung cancer, and there's different theories to why this is occurring. One is due to prolonged survival with novel therapies, such as we'll discuss in this lecture, and then also improvement of neuroimaging and improvement of screening. And part of these new targeted therapies are able to be developed due to recognition of different mutations, such as EGFR sensitizing mutations and ALK gene rearrangements. Around 25 to 50% of patients develop brain metastasis, and patients with EGFR and ALK mutated lung cancers are more commonly diagnosed with brain mets compared to those without the mutations. And the CNS typically serves as the sanctuary site of disease or disease progression in these patients, especially with first-generation TKIs, since they have low CNS penetration rates. And the ideal role of radiation therapy has not really been established, with different treatment options including whole brain radiation therapy, stereotactic radiosurgery or SRS, or possibly surgical resections for certain patients. And new second and third generation TKIs have increased blood-brain barrier penetration, are effective in controlling CNS disease, as we'll discuss in this presentation. But first, before going over different systemic treatment options, I just wanted to briefly talk about the role of whole brain radiation therapy. So since the 1950s, whole brain radiation therapy was really the standard of treatment for patients with multiple brain mets. And patients with whole brain radiation therapy are more likely to have neurotoxicity, which includes having a decline in learning function and cognition, and having a worse quality of life. In a recently published trial called the QUARTZ trial, which was a randomized, multi-center, non-inferiority trial, which compared whole brain radiation therapy for patients who were ineligible to receive SRS or surgical resection compared to best supportive care, which includes treatment with dexamethasone. And in this trial, there was no difference in overall survival for patients who were treated with whole brain radiation therapy compared to those patients just treated with supportive care. And there was a slight decrease in quality of life with patients treated with whole brain radiation therapy. So this leads to different questions on what is the role of whole brain radiation therapy for these specific patients. And now in the era of targeted therapy. So historically, median overall survival for patients diagnosed with brain mets is pretty poor, with 7 months, and the development of brain mets has been associated with a poor prognosis for patients with non-small cell lung cancer. Patients with ALK rearranged non-small cell lung cancer had a median overall survival of close to 50 months after the development of brain mets. And then EGFR mutant TKI naive patients who developed brain mets had an overall survival of 30 months. So these patients are living significantly longer than typically we've seen in the past. And now, considering the neurocognitive effects of whole brain radiation therapy and the distinct way that the disease progresses, we need to focus on making sure there's appropriate disease control without compromising quality of life for these patients. Before discussing different systemic treatment options, I wanted to talk about the blood-brain barrier. So the blood-brain barrier is a bed of capillary cells that regulate the transport of substances from the blood into the fluid around this brain and CNS. And this typically renders most chemotherapies unable to access the CNS and be able to treat CNS tumors. And it's usually due to their large size, hydrophilicity, protein binding, and efflux pumps. And there's different ways that substances can cross the blood-brain barrier. The first is through diffusion, so passive diffusion. So substances that are more lipophilic are able to cross this way. And second I wanted to talk about is through paracellular transport through tight junctions. So patients with brain mets actually have a disruption of their blood-brain barrier. So sometimes chemotherapy that's not normally able to cross the blood-brain barrier is able to cross through paracellularly, but it's believed that these chemotherapy agents are not able to reach concentrations that are cytotoxic in the CNS. And lastly, I just wanted to highlight efflux pumps. So there's different efflux pumps that are present on the blood-brain barrier, such as P-glycoprotein or PGP. And once substances are able to cross the blood-brain barrier, they can be rapidly transported out back into the blood and therefore unable to maintain cytotoxic levels. This slide highlights different EGFR TKIs blood-brain barrier permeability, and I just really wanted you to focus on the fourth column, which talks about the CSF penetration rate in patients with brain mets. As you can see, erlotinib and gefitinib have lower CSF penetration rate compared to osimertinib, which has been reported up to 16%. And all of these agents are believed to be substrates of PGP, or the drug efflux transporters. And next, I wanted to talk about the ALK TKI's blood-brain barrier permeability. And again, I just specifically wanted to highlight that fourth column. And as you can see, crizotinib has very low CSF penetration rate, being less than 1%. And even though ceritinib doesn't have formal studies in humans, in animal models, it's believed to be able to cross about 16%. And I just wanted to specifically highlight alectinib, which has 86% CSF penetration rate and is also not a substrate of the drug efflux pumps, such as PGP. All right, for the first ARS questions, what characteristics makes a medication more likely to have the ability to cross the blood-brain barrier and maintain cytotoxic levels? Is it A, hydrophilicity, being a non-substrate of PGP, high protein binding, or D, large size? All right, so yes, B is the correct answer. So being hydrophilic, those agents aren't typically able to cross through passive diffusion. Having high protein binding, there's less free drug to be able to cross into the CNS, and large size is also unable to cross through these tight junctions. So now I wanted to switch gears and talk about the data behind the use of EGFR TKIs for the treatment of brain mets. So this first study is an open label phase 2 study using frontline TKIs for patients with untreated brain mets. And this study uses erlotinib and gefitinib. And 28 patients were treated in this study, and patients were not allowed to receive any CNS-directed therapy before, so if they had radiosurgery, surgical resection, or whole brain radiation. And as you can see, 83% of patients were able to achieve a partial response, but if you see as the location of when they did progress, the majority of patients progressed in the CNS. So next I wanted to talk about osimertinib, which out of all the EGFR TKIs has the best blood-brain barrier penetration. And I just have a few trials summarized here. So the first study is pooled data from the AURA extension and the AURA2 trial, which included 50 patients with asymptomatic brain mets, and they used the dose of our standard 80 milligrams per day. And as you can see, overall response rate in the CNS was 54%, with 12% of patients able to achieve a complete response. The next trial is the Bloom study, which actually looked at patients with leptomeningeal disease. And although this is not the focus of my presentation, patients who develop leptomeningeal disease typically have a very poor prognosis, being 4 to 6 weeks if left untreated. They use a higher dose of osimertinib, and about 43% of patients were able to see radiographic improvement. And last study that I'm going to talk about is the AURA3, which compared osimertinib versus platinum-based chemotherapy, and 144 patients were included with stable asymptomatic CNS mets, and 46 patients had an evaluable lesion for response rate, and overall response rate was 70% compared to 31% with chemotherapy, and they had a significantly longer median duration of response, as well as significantly longer progression-free survival intracranially. So this shows that osimertinib has CNS activity that's superior to that of chemotherapy. The next study I want to talk about is the FLORA study, which was a double-blind phase 3 trial for upfront treatment for EGFR mutant non-small cell lung cancer. Patients were randomized to receive osimertinib or standard EGFR TKI, including gefitinib or erlotinib, and about 20% of patients had brain mets in this study. So now looking at the Kaplan-Meier curve to your left, I just specifically wanted to highlight this is the probability of progression-free survival. And as you can see, the red line represents standard EGFR TKI treatment, and the blue line represents osimertinib. And osimertinib had significantly longer progression-free survival for patients with CNS mets. And then specifically just wanted to highlight number of patients with CNS progression. So this chart breaks down their sites of progression. And as you can see, 20% of patients had CNS progression in the osimertinib group compared to 43% of patients treated with standard EGFR TKI. Next chart I wanted to highlight is just the response rate. And I specifically just wanted to highlight the duration of response because as you can see, there's not much of a difference in patients who had partial responses in this chart. But the thing I wanted to highlight is that the duration of response was significantly longer with osimertinib compared to standard EGFR TKI therapy. So from this trial, we can conclude that not only does it have CNS activity, but it also has superior CNS activity compared to standard EGFR TKI. I just wanted to switch gears a little bit just to talk about the role of radiation therapy and specifically whole brain radiation therapy for these patients. Because as I mentioned earlier, we do want to try to spare these patients of the neurotoxic effects. So this was a recently published retrospective pooled multi-center analysis, which included EGFR mutant TKI naive patients who developed brain mets. This study had a very strict exclusion criteria. The authors or investigators wanted to make it seem more like a prospective design, so they excluded patients with prior TKI use who failed to receive TKI therapy right after they completed radiation, and also patients who had less than 6 months of follow-up. And there were 3 groups in the study: patients who had EGFR TKI followed by SRS or whole brain radiation therapy. Upfront EGFR TKI, and at the point of progression, they received radiation. And just wanted to point out that majority of patients did receive erlotinib in this retrospective review. The second group is whole brain radiation, then followed by TKI therapy, and lastly SRS followed by TKI therapy. And since this was a retrospective review, there was a lot of differences between the baseline characteristics of each arm. The first upfront EGFR TKI, they were less likely to have symptomatic brain mets and more likely to have small lesions. And patients who were treated with whole brain radiation therapy were more likely to have poor prognosis compared to the other groups, and were more likely to have greater than 10 brain mets. So looking at the Kaplan-Meier curve, as you can see, the yellow line represents upfront EGFR TKI with deferred radiation therapy, and the gray line represents whole brain radiation, and the blue represents upfront SRS. And as you can see, upfront TKI had a worse progression-free survival and overall survival compared to the other 2 cohorts. But I just wanted to point out that this study did have a lot of limitations. Again, it was retrospective in nature, and they had a very strict exclusion criteria. So if patients did not have 6 months of follow-up, they were excluded. So it doesn't really let us know for patients who received whole brain radiation who had very poor prognosis, who were unable to receive EGFR TKI right after completion. If they passed away, they weren't included in this cohort. And then again, I want to highlight majority of patients receive upfront erlotinib, which we already know has poor CNS activity compared to osimertinib. So it's hard to draw real conclusions from this study, but I just wanted to highlight that there is still an important role of radiation therapy for the treatment of brain mets in this population. The next study I just wanted to highlight, even though this agent is not available here, icotinib, which is a EGFR TKI that's currently available in China, that's not available here in the US. And they did a multi-center trial for patients with EGFR-sensitive mutation in brain mets, were randomized to either receive whole brain radiation therapy plus chemo, compared to just EGFR TKI treatment alone. And as you can see, the TKI was superior in regards to progression-free survival intracranially and also overall response rate, but there was no difference in overall survival between the 2 treatment groups. The last study I wanted to talk about whole brain radiation is TKI alone or in combination with whole brain radiation therapy. And this was a retrospective analysis, so there are more limitations with this study. But I just wanted to highlight that patients who were treated with whole brain radiation and TKI in combination had a worse overall survival compared to TKI treatment alone. So this is a great chart that's for your reference, and it has the different lines of therapy, the different targets, as well as administration of drug interactions. I just specifically wanted to highlight the different adverse effects between the different TKIs, and erlotinib having more incidence of rash compared to gefitinib, which has more incidence of hepatotoxicity. And osimertinib has lower serious adverse events, less rash and similar rates of diarrhea, but there was more QTc prolongation and pyrexia in studies. So now for my second ARS question. Patient JM is a 68-year-old woman who is a previous light smoker diagnosed with metastatic EGFR exon 19 deleted non-small cell lung cancer currently being treated with erlotinib for 6 months, who presents with the chief complaint of headache and nausea, found to have 2 new brain mets seen on MRI with surrounding edema. Which following treatment options would be best for this patient? All right, A. So this is actually a very tricky question. So patients with asymptomatic brain mets were actually excluded from all the trials that I discussed, and our patient is clearly symptomatic with headache and nausea, but whole brain radiation therapy and the continuation of erlotinib would be inappropriate in this patient. If this option said SRS followed by erlotinib, that would actually be an appropriate choice, but out of all the options, osimertinib is the best treatment option for this patient. Now for the ALK inhibitors trials. So first I just want to talk about crizotinib, and we already mentioned that this has very poor CNS penetration rate, and again, this was our first ALK inhibitor TKI FDA approved. And I just wanted to highlight the second study, which is the Profile 1014, which included 77 patients with brain mets who were neurologically stable, and this compared frontline crizotinib compared to pemetrexed platinum-based chemotherapy. Intracranial disease control rate was at 24 weeks was significantly higher with the treatment of crizotinib compared to chemotherapy at 56% versus 25%. But if patients progress, brain as the sole site of progression of disease was much higher in the crizotinib group compared to TKI. And there was also a trend towards improvement in intracranial time to treatment failure, but this was not statistically significantly different. And even though that it seems like crizotinib is better than chemotherapy for intracranial disease control rate, this can also be due to the fact that crizotinib has superior extracranial disease control rate, therefore leading to decreased seeding into the CNS of cancer cells. The last trial on this slide that I want to talk about is the Profile 1005 and 1007, which included patients with untreated brain mets as well as treated brain mets who received crizotinib. And the patients with untreated brain mets, so these are patients who did not receive any previous radiation therapy, had an overall response rate of 18% compared to 33% who had treated brain mets, so significantly lower response rate with patients who did not have treatment. And out of the patients who had progression disease, 70% of patients in both groups had the CNS as a sole site of progression of disease. And also untreated brain mets had less time to intracranial time to tumor progression. So overall, crizotinib is not a great option for patients with CNS mets, and it often leads to the CNS to be the sanctuary site of progression of disease. So now moving on to ceritinib, and as I mentioned before, there aren't really formal human data, but it is believed to be a CNS penetrating TKI. And the first study that I'm talking about is the ASCEND-2 trial, which included patients with who had stable brain mets. Majority of them had previous radiation therapy, and 20 patients were able to be evaluated for response rate that had a lesion. And you can see that there were 2 patients who were able to who achieved a complete response, which is important to note. And then the next trial I wanted to talk about is the ASCEND-1 trial, and this included 124 patients with asymptomatic or controlled brain mets. So intracranial disease control rate was almost 80% with patients who did not receive any previous ALK therapy, and also 65% in patients who were previously treated with an ALK inhibitor. So again, even though this data isn't so strong, it does show that ceritinib does have CNS activity. The next drug I wanted to talk about is alectinib, which has the most CNS penetration rate out of all the TKIs. And this was an open-label phase 3 trial for upfront patients with ALK-rearranged non-small cell lung cancer. Patients were randomized to receive alectinib or crizotinib. About 40% of patients did have baseline brain mets, although they were either asymptomatic brain mets or leptomeningeal disease. If you see the cumulative incidence of CNS progression, the red line being crizotinib and the blue being alectinib, you can see crizotinib has a much higher rate of CNS progression compared to alectinib. Oops, sorry. And I just wanted to highlight as far as CNS complete response rate at the bottom, you can see up to 45% of patients were able to achieve a complete response with alectinib treatment. Switching gears to brigatinib, although I didn't report any CSF activity penetration on the first slide, when they were doing this phase 1, phase 2 trial, patients who had brain mets were actually able to achieve a response. So then they made an amendment and actually included patients who had active brain mets. And out of 15 patients who had measurable CNS disease, you can see one patient was able to achieve a complete response, and a majority of patients also were able to achieve a partial response, and you can see with the waterfall plot below. The next trial I'm going to discuss is the ALTA trial, which was an open-label multi-center trial for patients who previously received crizotinib, were randomized to different dosing schedules of brigatinib, and there were patients who had measurable brain mets at baseline. Again, they excluded patients who had symptomatic brain mets. And as you can see with this trial, there were patients able to achieve a complete response, and a majority of patients were able to achieve a partial response. And patients were able to achieve a partial response were more commonly with the higher doses of brigatinib compared to the lower dose. So in conclusion, for patients with asymptomatic brain metastasis, it is good to use a CNS penetrating ALK TKI, such as ceritinib, brigatinib, and alectinib. Although patients who are symptomatic, it's unclear about how we should treat them, and there's still an important use of radiation therapy. So if patients have CNS-only progression of disease, you can just use CNS-directed therapy, such as SRS, and continue their current treatment as long as their systemic disease is controlled, or you can switch to a CNS-penetrating TKI. Again, this is a helpful chart comparing the different targets, line in therapy, as well as drug-drug interactions and dose adjustments. Again, I just wanted to highlight the differences in adverse events. Crizotinib patients are more likely to have nausea and vomiting, vision changes, and patients treated with alectinib are more likely to have severe myalgia, CPK elevation, and less likely to have GI toxicity and vision changes compared to crizotinib. And then brigatinib has pulmonary toxicity as well as hyperglycemia and CPK elevations. So for our last ARS question, patient PW is a 48-year-old Caucasian male with a history of diabetes, glaucoma, diagnosed with metastatic ALK-rearranged non-small cell lung cancer, currently being treated with crizotinib with CNS-only progression of disease. PW received 1 dose of SRS and has been experiencing nausea with crizotinib. Which of the following TKIs would be the best choice for PW? All right, C, yes, that would be the correct answer. And this is mainly due to toxicity. So it is appropriate for this patient to continue crizotinib since they did receive radiation therapy, but since they were experiencing nausea, it would be beneficial to switch them at least to a CNS penetrating agent. And since they have a history of diabetes, using brigatinib, patients can have hyperglycemia. So alectinib would be the best choice for this patient. And with that, I'll lead you with my conclusion. So brain mets are commonly occurring in patients with EGFR and ALK-mutated metastatic non-small cell lung cancer. And these patients have a distinct natural history compared to patients with wild type. And therefore, with the introduction of new TKIs such as osimertinib, alectinib, and brigatinib, whole brain radiation could be spared in some patients without compromising quality of life. And managing symptomatic brain mets with TKIs really remains unclear due to exclusions in the majority of the trials. And with that, we'll take questions.
Thank you for that great talk. I do have a question for you, Samantha. Somebody who has, you're scanning them, how often would you scan their brain with an MRI if they don't have any brain mets already?
So that's actually a good question, and I'm not 100% sure of the answer. I know that we do MRI scans every 2 months for patients with known disease, but I'm not sure as far as surveillance what the current recommendations are.
Okay, thanks.
Thank you again. with regards to the immunotherapy colitis side effects, particularly with ipilimumab. I'm wondering if anybody has tried or if you've seen anyone use abatacept or Orencia, since it's a CTLA antagonist, and whether that would make more sense than going to a Remicade or something like that.
Sure, that's a good question, and I have not seen any reports of that in the literature yet, but I do think there's a lot of opportunity for pharmacists to be involved in research studies, because right now we're just using medications based on history of, takeover history from the management of graft versus host disease and bone marrow transplant and things like that, using steroids up front. And maybe there's other medications that are much more appropriate at this time, such as that example. So I think there's a lot more to be learned there.
Thank you for the great talk. This question is for Samantha. Can you comment on the high dose of the ernetinib, like 1,500 milligram once a week for the treatment of the CNS metastasis?
Yes, so I didn't include that study in the presentation just for sake of time. So erlotinib was actually, there was a retrospective review that came out of MSK, which used a dose of 1,500 milligrams once a week for patients with brain mets and patients with leptomeningeal disease. And these patients were able to have responses. And again, for patients who develop like T790M mutations, because erlotinib typically doesn't cross the blood-brain barrier well, it's hypothesized that those patients will not have those acquired resistance. Therefore, using these higher doses, you can still possibly treat these CNS mets. The only reason I didn't include this in this study is because the data isn't so strong with this, but in clinical practice, we have used it quite often. But I think now with the introduction of osimertinib, I believe that dosing regimen is going to be used less and less.
Two great presentations. Question for Christopher regarding patients with autoimmune diseases. We know that they were excluded in the studies, but they're not excluded in clinical practice. Mm-hmm. Patients come in, they're living longer, they have irritable bowel, et cetera, rheumatoiditis, psoriasis. What are your thoughts about treating those patients in everyday practice?
Yeah, so I kind of alluded a little bit to that. I didn't go specifically into that area, but I do think that when we meet with the patient and talk about the risk-benefit ratio, because that does come up quite a bit now, and really talking about that increased risk. There's just so many examples out there now where, yes, they do have an increased risk, but there are some case reports out there of safe treatment, and just really monitoring them closely after treatment, and starting steroids early. I think blocking that cascade is just so important. If you can stop it early, you can control it. If you wait until it gets really out of control, then it gets hard to manage at that point.
Okay, thank you.
Thank you.
All right, thank you guys. There's no other questions.